In this last section, I want to cover just a few points about renal failure, which is the end point of many of the diseases that we talked about in the prior sections. And then we'll end the lecture on renal pathology by talking about tumors of the kidney. Now, renal failure comes in two forms. It can be acute, like what you see in rapidly progressive glomerulonephritis, which is the development of renal failure over a matter of weeks, or it can be chronic, developing over years to decades. Acute renal failure manifests itself as acute azotemia, elevated BUN and creatinine, with oliguria, which is decreased urine production, and acute imbalances in electrolytes. Renal failure can be caused by falls into three different categories, and it depends on where the etiology of the renal failure occurs. You can have pre-renal renal failure, which occurs because of defects in the renal blood flow, that is, in the blood flow into the kidneys. So you can get this from shock, you can get this from obstruction, you can get this from congestive heart failure. Basically what happens is the kidney thinks that blood flow is decreased, and so you get increased tubular absorption of sodium and water. This results in oliguria, a more concentrated urine, and a decreased urinary sodium concentration. This can also be caused by acute tubular necrosis, in which the tubular reabsorption is impaired, and so urinary sodium is decreased. You can also get what we call post-renal renal failure, which is caused by obstructive uropathies, anything that causes the mechanical blockage of urinary flow. Or the most common cause of renal failure, which are the intrinsic glomerular or tubular interstitial or vascular diseases of the kidney. And these usually progress to chronic renal failure, except for those that cause rapidly progressive glomerulonephritis. Now, chronic renal failure causes a constellation of clinical signs and symptoms that we call uremia. Azotemia, which is increased blood urea nitrogen and creatinine. Metabolic acidosis, this is due to decreased acid secretion and decreased bicarbonate production by the renal tubules. Hyperkalemia, due to increased resorption of potassium. This can lead to cardiac arrhythmias. You can get sodium and water excess, leading to congestive heart failure and pulmonary edema. You can get hypocalcemia. Remember, this is called renal osteodystrophy. Remember that the kidney is responsible for converting vitamin D from its inactive to its active form, and that can lead to hypocalcemia. You can get anemia because the kidneys produce erythropoietin. When you get kidney failure, you get decreased production of erythropoietin, and that causes decreased stimulation of the bone marrow to produce red blood cells. You can get hypertension from increased renin production and activation of the renin-angiotensin-aldosterone axis. And you can get other miscellaneous clinical features, including neurologic disorders, skin disorders, platelet dysfunction leading to bleeding, and fibrinous pericarditis. All of these are clinical features of uremia, which is the end point of renal diseases. Now let's talk at the end about some of the tumors that we see in the kidney. Now, there are some benign tumors that you may see in the kidney. There are things called renal papillary adenomas. These are benign overgrowths of renal tubular cells. They're small, they're discrete, they're clinically insignificant, and usually only found at autopsy. You can also get angiomyolipomas. Now, the name says it all. This is angio, which means it's vascular, myo, which means it's muscle, and lipoma, which means it's fat. So these are hamartomas, which means overgrowths of mature tissues composed of fat, smooth muscle, and blood vessels. This can lead to clinical consequences in some cases and is associated with congenital tumor syndrome called tuberous sclerosis, which we discuss in a different lecture. You can also get oncocytomas. These are benign epithelial cell tumors composed of large eosinophilic cells having small, rounded, benign appearing nuclei. And it's this eosinophilic rounded appearance that gives it its name. These rounded cells are called oncocytes, whether they're found in the kidney or the thyroid or other places. These oncocytes are cells with this particular morphology. So when you get a benign proliferation of these cells, we call it an oncocytoma. Again, a benign tumor with very little clinical consequence. Now, to introduce the malignant tumors of the kidney, we'll give a clinical vignette. This is a 60-year-old male that presents with right flank pain and hematuria. He has a history of heavy tobacco use. When you do a physical examination, you can actually feel a palpable mass in his right flank. Laboratory examination of his urine reveals gross hematuria and an elevated hemoglobin. This is an example of renal cell carcinoma. This is the most common renal malignancy of adults. It's more common in males than females, and especially occurs in late middle-aged to early elderly people, which is ages 50 to 70 approximately. Individuals who smoke, especially who use tobacco for a long period of time, are more susceptible to developing this tumor. They can be hereditary, associated with hereditary tumor syndromes like von Hippel-Lindau syndrome, or more commonly they're sporadic, occurring in only a single location in a single kidney. Now, clinically, they presented this triad of flank pain, a palpable flank mass, and hematuria. Now, there are several paraneoplastic syndromes associated with this disease, including secondary polycythemia, which results from unregulated production of erythropoietin or erythropoietin-like molecules. And you can also get a parathyroid hormone, hyperparathyroidism from a paraneoplastic production of parathyroid-like hormone, or you can get overproduction of ACTH-like hormone to give various endocrine paraneoplastic syndromes. The tumor frequently invades the renal vein and the inferior vena cava, and so this leads to hematogenous spread of this particular tumor. Pathologically, what you see are polygonal clear cells, which you can see in this next picture. Here's a gross photograph of what a renal cell carcinoma will look like, with this polygonal or multi-sided formation of very clear cells, which is typical of renal cell carcinoma. Now, the most common renal tumor in children is what we call Wilms tumor. This tumor typically presents as a large flank or large abdominal mass in a child ages 2 to 5 years old, basically in toddlers. This is caused by deletions in two particular genes, the WT1 gene and the WT2 gene, which are tumor suppressors found on the short arm of chromosome 11. Now, when one of these two genes is deleted, you often see Wilms tumor in association with other clinical features. When you have deletion of the WT1 gene, you get what's called the Wager syndrome, which is Wilms tumor, aniridia, which is congenital absence of the iris in the eye, genital abnormalities, and mental retardation. It can also be part of a Beckwith-Wiedemann syndrome, which is associated with deletion of the WT2 gene on chromosome 11. The Beckwith-Wiedemann syndrome causes Wilms tumor, hemihypertrophy, which is enlargement of organs on one side of the body only, macroglossia, which is a thickened tongue, organomegaly, which is enlargement of organs, and neonatal hypoglycemia. That concludes the section on renal tumors and concludes all of the lectures on renal pathology.